All right, now we're going to talk about autism spectrum disorder in adults. We've talked about ASD in children and just kind of how that presents, some of the basics of what you would need to be looking for with that disorder in children, but how does it affect adults? One of the things you can see on the slide right here, one of the big things that we're going to be talking about is the brain, how the the brain that's affected with autism looks as it moves through the lifespan. That's one of the big things we're going to be looking at. Also, how the brain that does not have autism looks throughout the lifespan. One of the things you can see here is that there's definitely changes, that there's parts of the brain that are larger and there's parts of the brain that are smaller. It's comparing autism to control in this picture here. We'll talk about what that is, but that's where we're heading. And then also, this guy's got vegetables. I assume that this guy also has autism. I found him on Google when I looked for people with autism. But it could just be a guy with vegetables. Anyway, why do we know so little about aging in autism? First of all, I guess I should say we don't know a lot about aging in autism. That's the first thing I'm going to tell you. Let me get my head out of the way. So you can see this baby. So first thing I'll tell you, we don't know a lot about aging and autism, how people with autism go through the lifespan and become older adults with autism. We just don't. And so why don't we know a lot about that? Well, one of the reasons is the very first autistic child was diagnosed in 1942. Now that sounds like a long time ago, but he's still alive. He's in his 80s. He's 81. Is that right? Am I doing that math right? 81? Yeah, I think I'm doing the math right. Or 82. Sort of depends, I guess, where in there. Yeah. Roundabout, future-proofing the video. We'll just say he's 82 through 85. Then I don't have to make this video again for 2 years. So this is him. This is a picture of him. Right up here. Let's see, I'm down in the corner, so he's going to be up there. This is the very first child diagnosed with autism in 1942. And it wasn't a typical diagnosis. It's not like this Donald is his name. It's not like Donald was born and then all of a sudden everybody who has autism was then diagnosed. That's not the way diagnosis of diseases works. It kind of has to filter throughout the community, the medical community, I should say, and become something that a lot of doctors know about, so they know what to look for. And then more people start to be diagnosed. So in 1942, for quite a few years after that, decades after that, it just wasn't a thing that was largely diagnosed. Of course, there were still people who had autism, and there probably were throughout history. But as a medical diagnosis, it wasn't made until 1942, and then it was rare. There was also no diagnostic criteria. There were diagnostic criteria, but they weren't like easily obtainable diagnostic criteria until 1980. And 1980 is when autism was added to the DSM-3. The DSM stands for the Diagnostic and Statistical Manual. Great name. Of disorders, basically. So what it is, it's a handbook that psychologists and physicians have that they can go through, look at a list of things that a patient is presenting with and say, oh, it looks like this disorder, and then make a diagnosis based on that. So 1942 is when the first person with autism was diagnosed. And then 1980, almost 40 years later, is when it was added to the DSM. So not a lot of people are going to be diagnosed for that 40 years just because it's not a widely known thing. There's no central place where you can look up diagnostic criteria, but once it's in the DSM, then it's a little bit easier to find. And you do see a lot more people starting to get diagnosed with autism after 1980. Donald turns... That's wrong. I did the math totally. I don't know what I was thinking when I did this. He should be... Oh, wait. No. You're not diagnosed when you're born. So he was diagnosed in 1942. He wasn't born in 1942. So he's 88. 89 now. But he is... I just looked this up before I recorded the video. He is still alive. Well, I looked it up. I looked it up a few months ago. He was alive as... Let's just say he's still alive. It's happier. And this is him. Okay. So, here's a graph. Let me see where my head is in relation to this graph. Can you see this? No. I'm going to go up and cover up the baby. Okay. So, graph. Nope. Graph. This graph shows the number of people diagnosed with autism in different, across decades, with a few different markers on here. So you can see that in 1975, not a big diagnosis that's been made. It hasn't been added to the DSM yet. It's 1 in every 5,000 births. That's how many people are diagnosed with autism. 1985, it's been in the DSM for 5 years. Now we cut that in half. It's 1 in 2,500. By 1995, it's been in the DSM for 15 years, and the DSM has gone through at least one revision at that point. DSM-4, I'm trying to remember my years of knowing when the DSM comes out. I think DSM-4 was around when I was in college, but they were getting ready to do 5, so probably the DSM-4 was around. So it had been through 2 revisions by 1995. Is my guess. Well, there's a lot of years between 1995 and when I went to college, so maybe it had been through 2 revisions. It's not really a big deal. The point is, once the DSM is old enough to go through a revision, that means that a lot of people have gotten their hands on that book. Once it goes through one revision, people can get the old copy, just like textbooks. A lot of clinicians will do the same thing, especially if they're new clinicians just starting out. They'll buy an old copy. These books are extraordinarily expensive when they're new. They're multiple hundreds of dollars when they're new. So if you're a new clinician, like fresh out of graduate school or medical school, depending on which type of clinician you are, you might not have the newest of the new. So by 1995, it's out there. And then we get to 1 in 500. And then from there, it just continues to grow until the last place on this graph is 2009. It's 1 in 110 births are diagnosed as having autism. So it looks like it's just going to keep growing and growing and growing exponentially, but there's a graph more recent. Yeah, here we go. This is more recent. It includes more recent years, rather. But it does still start in 1970. And you can see that it actually seems to be leveling off. So 2009, they've got the same, roughly the same data here. 2006 is they're saying 1 in 110. This is saying 2009, but you know, somebody might have got their year off. And then it seems like it's starting to kind of level out, but still rise. And now we're at 1 in 54 births are on the spectrum in some way. So it's slowing down, but still rising. What could be the cause? There's a few different possibilities. We're going to talk about it in a second. Let's talk about prevalence first. So this is from the CDC, their most recent publication on autism, which was March 26, 2020. I know it's a little bit out of date, but not by much. Prevalence rates are the same for black and white children, which is great. I mean, it's not, great, everybody has a disorder, but it's good because that means that black and white children are being diagnosed at the same rate, which means that they can get services at the same rate. Because if you're not diagnosing people with autism, that doesn't mean they don't have it. It just means that they're languishing as neurotypicals and not getting the services they need. So it's great that prevalence rates are equal for blacks and whites. Hispanics are still behind. This is what they keep doing. But it's a lot less of a lag for Hispanics. So eventually they'll figure it out. They'll pull it up. They'll screen Hispanics as much as everybody else. And then those kids will get the services that they need. And adults will get the services they need too, which is what this whole lecture is about. More children are receiving developmental screening by age 3. That's obvious from what we just talked about, that if all different races are getting, their prevalence rates are equalizing, they're not equal yet, but they're equalizing, then that means that more children are receiving developmental screening by age 3, which is when you want to do it. You want to hit it early to make the most strides. Just like every other disorder that we've talked about, early identification is key. About 84% of children are getting screened by age 3. Here's an interesting thing, though. The diagnosis is different in Colorado, which is 1 in 76 children, versus New Jersey, which is 1 in 32 children. What is going on here? Well, to some extent, the DSM isn't perfect. None of these diagnostic criteria are perfect. It seems like what's going on is there's some criteria overlap. And what we see is that there's a dip in diagnosis of intellectual disabilities as ASD is rising. So what I mean by that is there were children who are characterized as having intellectual disabilities or being disabled in some way, diminished cognitive capacity, something like that. But as autism became a diagnosis that more people knew about, the ASD diagnosis is rising and the intellectual disabilities diagnosis is shrinking. Now, that doesn't mean that everybody with ASD has intellectual disabilities, not by any stretch of the imagination. Because as we've talked about with children, there's really very few criteria that you can say is common to everybody with ASD. There's a pragmatics is really the big one. And there's some other things we'll talk about, gastrointestinal disorders, oddly. But you can't say that everyone has diminished cognitive capacity. The opposite is also true. Sometimes extraordinarily high IQ can be seen with ASD. So just because some people that have been diagnosed as having intellectual disabilities in the past are now being diagnosed as having ASD, that doesn't mean that everybody with ASD has intellectual disabilities. What it probably means is that before ASD was a diagnosis that people knew about, people were being classified as having intellectual disabilities, and that's not what it was. It was probably people who had autism. The culture at the time didn't know about autism, and so they just thought, well, I guess he has intellectual disabilities. And so then they just put that label on the person as a way to categorize what was going on with them. You see this a lot with dissociative identity disorder and multiple personality disorder. So when there's a movie, geez, I can't remember what it was. It's like way before me. It was either Sybil or it was Three Faces of Eve. Again, these were popular way before I was born. Like, my parents were really young, long hair, probably smoking weed. These were popular back then. One of them, I don't remember which one it was. I think it was Three Faces of Eve. That's why she had three faces. Was a multiple personality. This became really, really, really popular in culture. And what you would see is that diagnostic rates of multiple personality disorder rose like exponentially, just like we saw with ASD. And then if you looked at dissociative identity disorder, it just tanked. So there's a lot of overlap in these diagnostic criteria. And because one is a little bit more popular in the cultural zeitgeist, then that becomes the one that is diagnosed. People noticed that they were probably overdiagnosing people with multiple personality disorder, and then what you saw was kind of a switch. Multiple personality disorder was here, DID was here, and then it kind of switched a little bit, and people became more reticent to diagnose people with multiple personality disorder, and people then were possibly overdiagnosed with DID. And that might be what's going on with some people that have autism, especially way far out on the spectrum where you get into the non-communicative areas. It's harder to diagnose there because you can't really see the way that that person is going to interact with you, right? So if you imagine someone with mild autism, you can interact with them. There's a pattern of behavior that you can see. You can observe that pragmatics might be what they're having trouble with. And you have a really good, you can be really confident that that's ASD. Previously, it may have been considered intellectual disability. But further out on the spectrum, where communication is much more difficult, that's harder to diagnose. And those things would be more subjective and more subject to what is popular in culture at the time. That could be a large factor. And there also could be environmental factors. But look, when I say environmental factors, vaccines are not the cause of autism. Okay, like, I think most of you are with me. The last time I talked about this in my in-person class, somebody said, does anybody actually still believe that? And the time before that I taught it in my in-person class, somebody confirmed that this is still something that people believe. So it's not the case. This guy, Wakefield, was the person who first wrote a paper that there was a connection between vaccines, I think it was MMR vaccines, and autism. He admitted that he faked the data. The paper was retracted from the journal that it was published in. He was removed from medical practice. I think the asshole ended up getting a TED Talk or something like that. I'm honest, and they've never given me one, but whatever. Anyway, he's admitted to faking the data. No actual scientific study that's been done to look at this link afterwards has found anything, and it's all just moved into like scare tactics and fake Facebook data with probably pictures of minions on them. You know how Facebook is. It's not that. But it could be... Whoop. Let me go back really quickly. So it's not vaccines. There are some environmental factors that we should be looking at. One study looked at pollution, air pollution. That could be related to autism. The jury's still out on that. The data is young. Hopefully we're not going to have another person lying about something that's correlated with autism. It doesn't seem like it because it's not like a slam dunk kind of paper. It's kind of like there might be a slight correlation. We're not really sure, which is like how real data actually is. So more research is needed to see if that's true. Another possibility is there are certain diseases that a mother can contract during certain times of pregnancy that can be related to autism. I think it's... You look this. I will post a note in this video and on Canvas, but I think it's just the flu in the third trimester. It might be a certain type of sickness that's not the flu. It might be like rubella virus in the third trimester. Whatever it is, it seems like it's in the third trimester. And that's more related to having a child who has autism. So there are some environmental factors. Air pollution, there could be ways to get around that, possibly. I mean, I don't know. live in a different place. But that's not something that's within the scope of this lecture. Why do we need to study aging in autism spectrum disorder, though? Well, I'll tell you why. It's not just that we need to know, like we talked about, that whole slide was about, like, where does it come from? Where does it go? Where does it come from, Cotton Eye Joe? Where does it come from? What is related to it? What's causing it? Why is it rising? And so that's all like developmental stuff. So if we're interested in where it's coming from, can we target it early? Can we prevent people from having ASD? Maybe. We don't know. I mean, if there's no environmental factor, how are you going to prevent it? Gene editing, we're a little bit of a ways off from that. So we can't do that. So why do we need to study aging in ASD? Because there will be 1 million plus elderly individuals with ASD in the United States alone by 2050. Less than 30 years from now, 1 million elderly people with ASD. That's a lot. And we have hardly any research about them. This picture right here, this graph here, is going to show we have a ton of research looking at children. There's a decent amount looking at adolescents. There's some looking at adults, and there's just this tiny little sliver looking at older adults. So essentially it's a population of people that we just don't know anything about. We don't know if there's issues, cognitive issues, social issues, anything that we should be looking at to try to help as clinicians. We don't know because they're not a population of people who have been studied well. In addition to that, people who have autism themselves are worried to get older. A lot of people with ASD rely on their family and other social support networks to live, as they're aging. They rely on parents. They rely on brothers and sisters, possibly cousins. But as parents start to get older and die, and the people with ASD become the ones who are older, and their siblings start to get old, who's taking care of them? They have never lived on their own. And so, what's going to happen to them? They're worried about this. They don't know if they can do it. In some cases, they can't. And so who's going to be around to take care of them? That is a really good reason why we need to study aging in ASD. One thing that we want to know, and we're not totally sure about this yet, is aging with ASD the same as typical aging? So can you just look at a regular person and the way that they change as they go through their lifespan, as they age, and say, well, that's just what's going to happen to people that have ASD as well? So just generalize it. Is that true? We don't know. We'll talk about some evidence today, but even though we're going to talk about some evidence and we have some tentative answers, there needs to be more research in the area. That's just all there is to it. Okay, so life for adults with ASD. There are a lot of persistent deficits in other conditions. So ADHD is something that is somewhat correlated with autism spectrum disorder. IBS and other gastrointestinal disorders are oddly related to ASD. Anybody watching this who has ASD and feels comfortable saying, does that ring true to you? Are there interesting gastrointestinal symptoms? I also wonder, because I have a lot of friends who don't have ASD, and there are a large range of gastrointestinal issues that they have. So just wondering if maybe a lot of people have gastrointestinal issues. Low employment rate, trouble living independently, that relates back, both of those actually relate back to what we were talking about being worried about getting older with autism. Poor mental health, so a lot of anxiety, depression, those are comorbid with ASD as well. Limited social network, they don't have a lot of people outside of their family that they connect with. And then also difficulty finding services to get the help that they need. Comorbid. I threw that word out at you. Let me talk about comorbid for a second. It sounds bad because it has morbid in it, and co. So it sounds like two goths, but that's not what it is. Comorbid just means that two conditions are essentially correlated with one another. So you could say co-occurring conditions. Co-occurring sounds like they're not related and they just happen to, they are there at the same time. So that would be co-occurring. But when two conditions co-occur a lot in a whole bunch of people, then we would say that they're comorbid. So it's like they're correlated, they're related somehow, they go together. That's just what comorbid means. It doesn't really have anything to do with like morbidity. Ooh. It just means that they're two things that go together. So this is just for adults, all adults, younger adults, middle adults, and older adults. This would be true for all of them. And you can see how as you age, these become more of a problem. ASD symptoms run this entire spectrum right here. There are some cognitive deficits. There's anxiety, hyperactivity, inattention, which is slightly blocked by my face, depression, obsessions or compulsions, so components of OCD disorder, sensory abnormalities, and disruptive behaviors. These can kind of be grouped into roughly two main areas. These restricted repetitive behaviors and interests, which we're really not going to talk about in this class, in this lecture, and also social communication deficits, which we are going to talk about because they're communication deficits. And then specifically, we want to focus on the cognitive deficits right now. So what are the cognitive deficits that we tend to see in regular aging? Well, with regular aging, we see a lot of executive function, declines in executive function. So we see problems with attention. Sorry, I just got the hiccups for some reason. Good. Problems with attention, inhibition, problems with planning, decreases in working memory capacity, and less cognitive flexibility overall. So then we want to know about how ASD impacts the brain. Not necessarily in aging populations. So we looked at just aging. Now we're looking at just ASD in adults. So one of the things that we want to look at here is brain volume. Difference in brain volume, it roughly correlates with where deficits are going to occur. Think back to neuroanatomy. We talked about it just a little bit. If you've had 310, which you probably haven't because it comes after this, but there's a lot of neuro stuff in there. So we talked about it a little bit in a few lectures ago. So think back to your neuroanatomy. The frontal region, this is where a lot of executive function decision-making and stuff is going on. Temporal, sound processing, sensory integration, a lot of stuff like that's going on. Parietal, motor, and also sensory integration. Occipital, visual system is back there, mostly visual stuff. This is a really, really, really huge oversimplification. There's a lot of stuff that all those lobes do that I haven't talked about, but that's kind of like their big function. Kind of like if you just name a state and say like their biggest export is blank, it's kind of like that. They do a lot more than just California movies. Yeah, but they also make garlic. So that's kind of how the lobes are. But essentially, you can think about the lobes that way, just as a rule of thumb. So ASD affects the frontal lobe more than the others. So if we look at brains of typically developing brains, and we look at the brain volumes of brains with autism, we see that there's a volume difference corrected for overall size, because brains are different overall in size. Everybody's got a different size brain, happy little snowflakes. But when you correct it for the size, you can look at the size of those lobes overall in reference to the size of the brain. And what you see is this large colorful graph below me here. where occipital, there's not a lot of difference. Parietal, there's not a lot of difference. Temporal, there is. And frontal, there's a lot of difference. And so we see a lot of difference in the frontal lobe with ASD. That means that there's less volume in brains with ASD in this frontal region. That mimics the aging brain. So if you consider some of these ideas that we see in aging, problems with attention, inhibition, planning, working memory, and cognitive flexibility, pragmatics would definitely come into play with some of those. So typical ASD mimics what we already see in the aging brain. We also see there's overall brain volume changes, not looking lobe by lobe. We can just see in general. People with ASD tend to have a really rapid just explosion of growth in the brain early in life. You can see that on the dotted line over there. And then the brains tend to shrink down a little bit, and people who are neurotypical are going to kind of come up and grow a little bit beyond that. So the brain volume overall after an explosion around age 4 is then lower, so less volume overall, less total cranial volume overall. That's in the graph on the left. On the right, you're going to see essentially the same thing, just later into life, that people with ASD lose brain volume faster. So this is looking off into life, modeling it out into 50. I think this actual model went out even beyond 50, and they're just showing 50. I'm not 100% sure about that. But you can see that there is some loss for everyone as we get to out in towards 50. But people with ASD are losing that brain volume a little quicker. Okay. So how does aging impact ASD? We know something about aging. We know something about ASD. And that is that the frontal lobe is impacted in both cases. Typical aging and ASD have similarities in brain volume loss, I should say in brain volume loss and placement of brain volume loss. Does this mean that people with ASD are more susceptible to age-related loss? So essentially what we want to know is it like the brain on the left where you have normal aging and there's ASD and they kind of do their things and they don't really interact? Or do we see brains more like on the right where you have aging and that's exacerbated by the effects of ASD and they kind of work together to increase the deficits that we see in both cases alone? One way that we can test executive functioning, there's a few different ways. Working memory tasks, and we've talked about that in some lectures that we've already had. I've mentioned it briefly, and then further off in the class when we talk about stroke and aphasia, we're going to talk even more about working memory. So you can look it up, you can ask me, or you can look in my list of videos on YouTube and find the one on stroke if you're curious about working memory. I might have some videos just about working memory also, so you can look those up. There are also some tests of cognitive flexibility, like this one called the Wisconsin card sort test. So essentially what's going on with the Wisconsin card sort test is you get a card, and you have to sort it. You can sort it on a few different things. You can sort it on number, so the number of the things. There's going to be like 1, 2, 3, or 4 objects, and you're trying to match it to another one. And so is the match the number? Is the match the shape? There's square, circle, star, and plus sign, I think. And so that could be the match. Or there's color, and there's red, blue, yellow, and green, and that could be the match. So you have 4 possibilities in each of these different match conditions, and you just have to guess what the match is. Let me show you. So this is the link that I have on there. You can play this on your own with the slides that you've got. If you don't have the slides for some reason, pause the video and go right there. All right. We're going to run the demo. You have to do this because there's a sound that it makes when you get it wrong that is hilarious. Okay, I've totally read these, and I'm not going to read the instructions because I've read it a lot. Except I don't know that Q starts it. Okay. Okay, so the match here could either be number or color. Color and shape are the same. I'm going to go with that one. Good. Okay, so it's either color or shape. So now we just have to figure out, is it color or shape? Let's do shape. It's shape. All right. So triangle. And now we're in. Now we just keep matching the shape until they change it on us. And they get you kind of like lulled into a false sense of security. You're just matching shapes like you're a baby at the doctor's waiting room, you know, or like at the bank. They've got those things and you match shapes. We all did it, I'm guessing. I still see them. So babies even now are doing that while their parents are talking about home loans. Wrong. Okay, it's not shape anymore. Shoot, changed it on us. Okay, so it's not shape. It's got to be either color or number. Let's do number. Yeah. Okay. So 3 and 4. And so what's going to go on here is if you don't have good cognitive flexibility, you can't update your rule. So we know now that the rule has moved to number from shape. But somebody who can't update that, who doesn't have good cognitive flexibility, would try to go back to shape and not be able to keep it updated with a number. Just from doing this while I'm talking to you, I can definitely tell you that they've updated it. It's not number again. Let's go with color. Yeah. All right. I can definitely tell you that doing this while explaining it and talking to the camera is adding a whole other level of cognitive flexibility that you have to have. Okay, I think we've done it enough. Back to the lecture. We've also got imaging research that we can do in addition to these kind of behavioral tasks. Some of the research that's been done show that young adults with ASD have thicker frontal cortices than neurotypicals. Middle-aged adults with ASD have thinner frontal cortices than middle-aged neurotypicals. But there's no difference in the occipital lobe. Remember, the occipital lobe is where vision is processed back here in the back. And, of course, frontal is where decision-making happens. So ASD is, I don't want to say preferentially, like diminishing the frontal cortex, because that sounds good almost, but that is what's happening. It's targeting the frontal cortex. And you can also see that this is compounded with age, because younger adults with ASD have thicker frontal cortices, but then middle-aged adults have thinner frontal cortices. So it's not just an effect of ASD, it's also an effect of age. Here's the Wisconsin card sort task. We basically see the same thing. Young adult, there's really no difference. Those boxes and circles are like a little bit different, but there's no significant difference there. But once we move to middle age, you can see that ASD is separated from neurotypicals by a significant amount. And now they're making significantly greater errors. We can also look at social communication deficits with ASD. Some of these deficits are initiating and reciprocating social interactions, maintaining relationships, and use and interpretation of nonverbal communication. Remember, this all kind of, again, goes back to pragmatics, just like we talked about. This picture over here at the bottom, super creepy. Just wanted to throw that in to freak you out. Okay, so ASD symptoms across the lifespan. This graph shows what happens from childhood to young adulthood. ASD symptoms seem to alleviate to some extent. This doesn't mean that ASD is going away. This means that with services, learning happens, essentially. Things that, like pragmatics, that aren't picked up on easily by people with ASD are able to be noticed with work. It takes work. What's underneath my head is reasoning. And then under that, we've got decision-making, judgment, and inhibition. These all come together to make social skills. So we can teach all of these things. We can teach people with ASD, hey, pay attention to what's going on. Pay attention to the way that decision-making is happening. Pay attention to judgment. Use more inhibition, and then take reasoning in this different way. And that can lead to the social skills that help them get along in life. This is the full picture, though. As we go into middle age, we've hit a plateau. And then as we get into old age, the symptoms are getting a little bit worse. Why is that? We see increased core symptom impairments in middle age and older adults. We see poorer social outcomes at longitudinal follow-ups during middle age. This means that people with ASD are basically seeing their symptoms get worse. We are seeing them age quicker, or we're seeing a resurgence of ASD symptoms. Either way you want to put it, it's sort of true. We can see that there is a greater amount of social communication impaired. Blue bar is middle age, red bar is young adults, and you can see that there's a greater amount of social communication impairments. We can also see that there's differences in the way that the executive network functions. There's a lot of stuff going on here. I've just hit you with a ton of data. I'm going to hit you with a little bit more. Whoa, sorry. This is actually a really cool study. We're looking at hypoconnectivity. Hyperconnectivity would be like a lot of neurons connecting. Hypoconnectivity is a reduction in the amount of neurons that are connecting to an area. We are looking at hypoconnectivity in ASD and aging. We typically see that in both of these areas. And this is a study combining the two. So on the left, you're going to see the left dorsolateral prefrontal cortex. That's a large area for decision making. And what you can see is the blue bar is neurotypicals. And there's a little bit of a decline with aging, but not much. It might not even be a significant change. For people with ASD, that's quite a drop as you go from young adulthood to middle age. On the right, we see the same thing for the right dorsolateral prefrontal cortex. Again, not really any change for neurotypicals, and the same sort of decline for people with ASD. Essentially, what I'm saying here is this last point on the slide, which is you have exacerbated hypoconnectivity in people with ASD who are aging. You see hypoconnectivity with ASD and aging, and you see it doubly so people who are aging and have ASD. This is another slide essentially showing exactly the same thing. Lower levels of connectivity in the prefrontal cortex correlated with greater social difficulties. So basically, what's happening is, if you think back to those two brains, we wanted to know what's going on. Is it just that aging has an effect and autism has an effect? Or do aging and autism interact and kind of exacerbate the effects of each other? It seems that they exacerbate the effects of one another. If you have autism and you are aging, your symptoms are getting worse. And you have less social supports. So that is why this area is so important for research. We can't help these people until we know more about the problem. So older adults with ASD are going to have increasing problems as they age. In young adulthood and middle adulthood, they can seem really, they'll seem different than they are as they age. The symptoms will resurge and be worse. We don't yet know the full extent or list of these problems because we just don't have enough research. We absolutely have to have more research in this area to know what we need to be looking for, what kind of services we need to be providing, what can we do to help these 1 million plus people who are going to have these problems. And that's 1 million plus by 2050. But as you saw with those graphs, it's growing every year. So we're going to have 1 million plus by 2050, but it's going to just keep growing from there. And we need to know more about it. So if this is an area that you found really interesting, maybe you should consider a different kind of graduate school. Maybe you should consider getting a PhD like what I have. Go into this area, go into neuroscience, or go into clinical work with a population that has ASD to do more behavioral research with them, so we can uncover more about what's going on and try to make more of a difference for the rest of that lifespan. Okay, sorry to kind of end on a bummer there, but it's important. All right, I will talk to you in the next lecture.